Go ahead and call the hearing to order. Good afternoon, everyone. Today, the subcommittee meets to hear testimony on military treatment facilities, or MTFs, which are the medical centers, hospitals, and clinics that are owned and operated by the Department of Defense and the military services. For decades, military treatment facilities have been recognized as the foundation of military medical care. They are the primary location for active duty military to receive treatment and are the training and education platforms for medical providers worldwide. Every member of the military healthcare team, me included, has spent time in MTFs. If you have served in the military, chances are you have received care in an MTF for everything from immunizations to routine health screenings prior to deploying to witnessing the birth of your child. Depending on the size and location, MTFs provide a wide range of medical services to active duty family members, retirees, and retiree family members. However, military healthcare, alongside civilian healthcare, has evolved, and we have seen many changes to MTFs. The certainty that a military installation will have a full-service medical facility is a thing of the past. For example, in 1989, there were more than 500 military medical facilities worldwide, 168 military hospitals, and hundreds of clinics. Today, there are 55 hospitals and 360 clinics for a total of 415 MTFs. Large medical centers, such as Fitzsimmons Army Medical Center, once considered an enduring capability, have closed. The reasons for some of these changes are varied. Healthcare has largely shifted from an inpatient focus to outpatient settings, such as ambulatory surgery, and care models, such as patient-centered medical homes. Another reason, unique to military medicine, is the realignment of troop units and closure of military installations, which has shifted the need for medical care among different locations. So the question we now ask is, what is the future of military treatment facilities? How do they maintain the primary mission of readiness of the force and ready medical professionals? Are MTFs currently situated to support the readiness mission along with the mission to provide care to their beneficiaries? I'm interested to hear from our witnesses about the challenges of running an MTF. How are MTFs different than civilian medical facilities? How does MTF leadership balance readiness requirements and the needs of the beneficiary population, including service members, family members, and retirees? And finally, what can we do to ensure the military health system has trained and ready providers to support the readiness of the force and provide a valued health benefit to our beneficiaries? With that, I want to welcome our witnesses, and I look forward to their testimony. Before I introduce our panel, I'd like to offer Congresswoman Susan Davis, our ranking member from San Diego, an opportunity to make her opening remarks.
Thank you, Mr. Chairman. I also want to welcome our witnesses, and thank you very much for joining us today. You know, over the past several months, we've met with senior leaders of military medicine who have discussed the policies of providing health care to the force and their families. And we've also heard from beneficiary organizations that represent those on the receiving end of health care services. So today we have this unique opportunity to meet with the four of you, the military treatment facility commanders, 3 words, but they're all really important, all separate, who execute the policies, interact with the military providers as well as the beneficiaries affected by those policies and healthcare services. So I look forward to our discussion and hearing from each of you how you balance the requirements of maintaining medical readiness for your providers while providing access to quality healthcare for your beneficiaries. And what can we do to help you in that endeavor? Thank you all so much for being here.
Thank you, Ms. Davis. We are joined today by another outstanding panel. Given the size of our panel and our desire to give each witness the opportunity to present his testimony and each member an opportunity to question the witnesses, respectfully remind the witnesses to summarize to the greatest extent possible the high points of your written testimony in 5 minutes. The lighting system before you, when you have 1 minute left, it'll turn yellow. When you're out of time, it'll turn red. I assure you that your written comments and statements will be made part of the hearing record. So let me welcome our panel. Colonel Mike Heimel, United States Army Chief of Staff, Walter Reed National Military Medical Center. In interest of disclosure, I was on staff at Walter Reed from 1998 to 2001. Colonel Mike Place, Commander, Madigan Army Medical Center at Joint Base Lewis McChord. Captain Rick Friedman, United States Navy Commanding Officer, Naval Hospital Camp Lejeune. And Colonel Douglas Littlefield, United States Air Force, Commander of the 19th Medical Group at Little Rock Air Force Base. Colonel Heimel, you're recognized for 5 minutes.
Thank you, Chairman Heck, and I was also on staff at Walter Reed 1998 to 2001, so it's great to have another alumnus of the Georgia Ave campus. So, Sir, Ranking Member Davis, distinguished members of the committee, Mr. O'Rourke, it's great to see you again, sir. Thank you for the opportunity to discuss the role of our military treatment facilities play in supporting military readiness and how we care for our beneficiaries. I am the Chief of Staff at Walter Reed National Military Medical Center, and until this past Monday, I served as the center's interim director. I'd like to take a moment to highlight what we at Walter Reed are doing to ensure our staff are well prepared for future deployments and how we are enhancing access for our patients across the National Capital Region while we continue to care for America's heroes from around the world. Walter Reed is the largest MTF in the National Capital Region, enhanced multi-service market. Together with the Fort Belvoir Community Hospital and 9 smaller MTFs, we are partnering to improve access to care for more than 245,000 TRICARE Prime enrollees across the National Capital Region. Today, providers from Walter Reed are seeing patients in nearly every one of those MTFs across our market in order to make care more convenient for our patients, eliminating the hassle of having to fight Beltway traffic to come to Bethesda. We are also streamlining functions like appointing and referral management to gain efficiencies and improve access. My written testimony highlights several of the programs which Walter Reed Bethesda is internationally renowned for: the Military Advanced Training Center for Amputee Rehabilitation, the National Intrepid Center of Excellence for Traumatic Brain Injury and Psychological Health, and the Murtha Cancer Center continue to lead our nation in developing evidence-based innovations that serve both a critical military medical need, but also critical needs within American medicine. Our co-location with the Uniformed Services University of Health Sciences and the National Institutes of Health allow us to develop partnerships that better integrate education and research into patient care. These partnerships also afford us the opportunity to collaborate with renowned leaders in trauma care, cancer care, and infectious diseases, improving care for our patients today while preparing our team for the deployments of the future. We're also expanding this partnership to include our local and regional Veterans Administration medical centers so we can improve access to care for our veterans. Our veterans are as much a part of the military family as anyone who comes to us for care, and it's a privilege to care for them. These veterans are also often our most critically ill and complex patients, which exercises and strengthens the same critical care skills our entire team, providers, nurses, technologists, medics, and corpsmen, all need to care for a critically ill or injured service member on the battlefield, en route to higher level of care, or back home at our MTFs. Thank you again for the opportunity to discuss these efforts with you, and I look forward to your questions.
Chairman Heck, Ranking Member Davis, and distinguished members of the subcommittee, thank you for the opportunity to represent Madigan Army Medical Center and Army Medicine today. Since 1944, Madigan has been a provider of world-class patient care, an unparalleled education facility, and a state-of-the-art research platform. Madigan cares for over 100,000 beneficiaries with around 5,000 staff members, supports over 250,000 beneficiaries as the tertiary referral hospital for the Puget Sound Enhanced Multi-Service Market. Madigan supports Joint Base Lewis-McChord, one of the nation's premier power projection platforms, home to 1st Corps, 7th Infantry Division, 1st Special Forces Group, the 62nd Airlift Wing, and a variety of smaller units. Our forces are aligned to the U.S. Army Pacific and are integral to supporting partnerships and exercises in the region, as well as operations around the world. Madigan has a twofold readiness mission to ensure our service members are medically ready to deploy and generating and maintaining ready medical forces. By collaborating closely with our line commanders as well as unit medical and dental providers, we have increased the available rate for soldiers in 1st Corps to nearly 91%. We will continue to work with our senior mission commander, Lieutenant General Lanza, to identify means to continue to improve the readiness of our soldiers, such as by increasing the availability of physical therapists for injury prevention or through implementation of the Army's Performance Triad. As an academic medical center and one of only 2 designated Level 2 trauma centers in the Army, Madigan plays an important role in ensuring we have ready medical forces. In 2015, Madigan trained 319 individuals in graduate medical education in 33 distinct training programs. Our residency programs boast a 95% 3-year first-time board pass rate, readily exceeding the national average of 87%. Madigan's orthopedics, neurology, and radiology programs in-service examination performance this year places them in the top 10% of the nation, and our emergency medicine residency remains one of, if not the, top in the country. Most importantly, our graduates are prepared through a unique military curriculum which provides them the tools to successfully transition to serve as surgeons in maneuver units or to serve in forward surgical teams or combat support hospitals. As a hospital commander in Afghanistan, I witnessed firsthand how our GME and related medical training programs provided the capability to achieve our unprecedented 92% survival rate despite the increasing severity of injuries sustained in modern combat. However, the Army cannot focus exclusively on sustainment of trauma skills and surgical capabilities alone. My experiences supporting the 75th Ranger Regiment in Operation Uphold Democracy in Haiti and as a medical task force commander during the Kosovo Air Campaign shows that Army medicine must be prepared to support a wide range of crises, from peacekeeping to disaster relief to humanitarian assistance. Military treatment facilities like Madigan are vital to ensure our medical teams are trained, ready, and relevant to provide care globally. Our partnerships with the VA and the civilian community strengthen our programs by providing a diverse and complex mix of patients to hone our skills for our entire medical team. I am personally committed to improving the readiness of our soldiers and our medical teams so they can best serve our nation. On behalf of Team Madigan and Army Medicine, I want to thank Congress for your continued support. I look forward to your questions. Thank you.
Chairman Heck, Ranking Member Davis, distinguished members of the committee, thank you for providing me the opportunity to share my perspectives as Commanding Officer, Naval Hospital Camp Lejeune, on the role that military treatment facilities have in providing medically ready service members and ensuring an operationally ready medical force. We in Navy medicine are privileged to care for those entrusted to our care. Naval Hospital Camp Lejeune is a family medicine teaching hospital located in eastern North Carolina, providing medical support to forces stationed on and around Marine Corps Base Camp Lejeune, to include members of the 2nd Marine Expeditionary Force and members of the Marine Corps Special Operations Command. The primary reason we exist is to build and sustain medical readiness. At Camp Lejeune, readiness takes 3 distinct but equally important components. First, readiness means that we, as medical professionals who wear the cloth of our nation, are ready at a moment's notice to deploy in support of our Navy and Marine Corps team. We must be physically, professionally, spiritually, medically, administratively ready to move out at a moment's notice. Our MTFs are the reservoir of forward deployable expeditionary medical support for our combatant commanders. Nowhere is that better understood than aboard Marine Corps Base Camp Lejeune, where it's common knowledge that no Marine has ever taken a hill without a United States Navy corpsman. Second, readiness means that we ensure our Marines and sailors are ready to be the first to fight in any theater of operation, and we understand their demanding mission. Several of our clinics are located around the base and are staffed jointly with medical personnel assigned to both hospital and assigned to operational units. This initiative improves access, continuity, and quality of care and provides expanded capabilities for our teams to collaborate during real scenarios, as demonstrated during our recent successful response to 2 recent mass casualty events following training mishaps. A third but equally important mission is caring for our families, because our team understands there's no sure way to make a combat Marine, soldier, sailor, airman, guardman more ineffective than to have them worry about their family. Family readiness supports force readiness. We at Camp Lejeune are committed to being leaders in quality, safety, access, and service. NHCL is proud to be among the first to employ available technologies to increase how our patients communicate with our providers. From our patient smartphone application to 100% primary care manager use of secure messaging to strong support of our nurse advice lines, we are ensuring patients have 24/7 access. Another of our access initiatives is launching our tele-ICU project, virtually connecting our intensive care unit with that of Naval Medical Center San Diego. Use of digital radiology and telepharmacy throughout our multiple clinics spread out over the 246 square miles of Marine Corps Base Camp Lejeune. We are proud to note that we have implemented the Centering in Pregnancy program that offers mothers-to-be a unique group prenatal care model that promotes education and peer group connections. It has been extremely popular with many of our patients, particularly those lacking built-in support system, a deployed spouse, or other challenges associated with military service. It is critical to note the importance of our hospital given the location in eastern North Carolina and the vital role we play in a medically underserved area of our country. There are wonderfully talented and dedicated civilian medical partners in Jacksonville and the surrounding areas. However, our community does not have the medical infrastructure which may exist in other metropolitan areas. Camp Lejeune's Family Medicine Residency Program has received the highest level of certification by the ACGME, has grown by 50%, and achieved 4 years of unprecedented 100% board pass rate for our residents. Their reaffiliation with our retired beneficiaries, who have doubled in size in the last 2 years, has really improved the acuity and complexity of cases for our interns and residents and specialists, and allowing our team to care for those who have previously served and who deserve the best that this nation can offer. An integral aspect of care, which has no counterpart in the civilian community, is our Intrepid Spirit Concussion Recovery Center. This center offers exceptional support for our service members afflicted with traumatic brain injury. A hallmark of the Intrepid Spirit Center is a holistic, integrated, interdisciplinary treatment approach that includes 10 different specialties to include complementary alternative medicine techniques. Care is tailored to meet the unique needs of the warrior athlete, and to date, approximately 2,000 of our warfighters have gone through the program, with over 90% of them, at least from the standpoint of TBI, returned to full duty. In summary, we are a critical part of the greatest and most highly capable Navy and Marine Corps team that the world has ever known. Our hospital serves as a readiness platform for the force and families stationed in the area. We will continue to be a forward deployable expeditionary medical capability while maintaining the highest levels of readiness. Thank you for your support of military medicine, and I look forward to answering your questions.
Chairman Heck, Ranking Member Davis, and distinguished members of the committee, I too thank you for the opportunity to come before you today on behalf of the men and women of the Air Force Medical Service. As commander of the 19th Medical Group in Little Rock, Arkansas, my job includes leading a team of 350 dedicated active duty, government service civilian, and contract employees in supporting a population of 44,000 beneficiaries within a 40-mile radius from our clinic. Of those beneficiaries, approximately 14,000 are enrolled directly to our clinic and receive care across our spectrum of provided services, such as our family and women's health clinic, flight medicine, optometry, and dental clinics. Some of the more unique services include both public health and bioenvironmental sections, as well as our aerospace physiology and high-altitude airdrop mission support team that directly support a myriad of U.S. and coalition partners in conducting operations in unpressurized aircraft between 10,000 and 35,000 feet in altitude. Each day, we strive to provide trusted care to the population we serve while continually looking for ways to provide safer, more efficient care and remain in touch with our patients' needs. Supporting the mission is our first priority. It is why we exist and where we focus our daily efforts. At Little Rock, this means combat airlift anywhere, anytime. Our actions ensure our active duty population are ready physically, mentally, and emotionally to carry out their role in supporting the Wing's mission. It also means caring for family members, retirees, and their dependents with the services that we provide. Ultimately, military readiness is community readiness, and leading my team to recognize the role they play in this priority has benefited all involved. The next priority we focus on is people. Our amazing teammates are how we get this mission done, and we strive daily to treat our patients, family members, community partners, as well as each other with the utmost respect and professionalism. We are committed to resiliency in every area of our lives, which makes us more productive and better teammates. We also look for opportunities within the clinic, wing, and community to grow personally and professionally so that we can continue to become better airmen. Our final priority is communication. There is no substitute for clear and concise communication at all levels, which allows our team to function at its peak. We are always looking for opportunities to improve our communication methods by listening more than we speak and utilizing different sources of information across our available spectrums to get pertinent messages to those we support. By focusing on these priorities, we are committed to supplying safe and high-quality health care to all those we serve. While the pursuit of this may look different at each location, the Air Force Medical Service will provide trusted care anywhere as we strive for peak readiness and the highest reliability in all we do. Thank you for the opportunity to speak on this matter and for your continued support.
I thank you all for your testimony. We'll now move into rounds of questioning. Each member will be limited to 5 minutes. We will go in the order of arrival prior to gavel. Hopefully, because I know I have several questions, we'll have time for multiple rounds. And I'll start, Colonel Hamill, the interesting thing about Walter Reed is that you're under the command of DHA and not a service. Can you give some insight as to how that works, answering to the Defense Health Agency as opposed to a service sector? And, do you see pros and cons to having that type of an alignment?
Sir, from a functional alignment, based on my experience commanding within Army medicine, DHA really functions like a regional medical command or a regional health command. for us. That's where our resourcing comes from. It's where our policy guidance comes from. And so it's really not much of a different relationship between Walter Reed and the National Capital Region Medical Directorate and the Defense Health Agency. I think some of the challenges with the way we're organized is within the National Capital Region Medical Directorate, Defense Health Agency only operates 2 MTFs. And so when we look at resourcing, when we look at allocation of civilian hiring caps that are in place to allow us to bring civilians on board, we don't have the degree of flexibility that Army medicine, Navy medicine, or Air Force Medical Service have, given the size and the scope of their regions. We have about 4,500 civilian authorizations across the National Capital Region Medical Directorate. I'll compare that to my time at William Beaumont Army Medical Center in El Paso, when Western Regional Medical Command at the time had over 11,000 authorizations. And so it makes flexibility in hiring and shaping our workforce much more challenging.
Great, thank you. Colonel Place, you mentioned that Madigan was a level 2 trauma center, one of only 2 within the inventory. Are you integrated into the civilian EMS system, and do you receive civilian casualties from trauma into your trauma center?
Yes, sir, absolutely. We're part of the Tacoma Trauma Trust. As that, we back up 2 civilian hospitals downtown. We average about 1 and 1.5 activations of our trauma team every day. So we are basically the backup 365, 24 hours a day for anyone else.
And how critical would you say that integration with the civilian trauma center is in being able to maintain the trauma skills of your staff members?
Sir, I think it's enormously important. We have only one level 1 trauma center down in San Antonio. I think it's important that we routinely see trauma in order to maintain those skills for not just the surgeons, because they are relatively easy to get to a trauma center to go do trauma, but as you know, it takes a lot more than just the doctor to be able to do those things. You need to have the ER trained well. You have to have anesthesia, and the PACU, and the ICU. All of those need to have training. The pulmonologist, the respiratory techs. Everybody needs to be part of that. So if we don't see any trauma, that is a challenge for us. And I personally would like to see more, because I think that adds to our capabilities when we go to war.
Could you summarize how that relationship was established between Madigan and the civilian hospital system?
So, sir, I'm not familiar with the actual history of that. I understand it was more than a few years ago that was put in place. So I can get back with you for the details if that's important. But right now, we're in discussions with our counterparts down there to make sure that we're all fulfilling our roles and responsibilities as part of that.
And as part of that relationship, do some of your providers rotate out to civilian hospitals, or is it all done based on the civilian trauma patients coming to your facility?
Yes, sir. We have some external resource sharing agreements where we send some of our folks downtown. Right now, probably the most dramatic is our cardiothoracic surgeons. They go downtown to perform surgeries there to maintain their skills. We don't have enough caseload within our population to really allow them to maintain their skills, so we let them go downtown with preferential treatment of our beneficiaries, but even so, we end up doing some VA cases and things like that downtown.
Great, thank you. Since my time is almost up, I'd rather not shoehorn an answer into my next question, so I'll wait for the next round. Mrs. Davis.
Thank you, Mr. Chairman, and again, thank you all for being here. We have heard from a variety of sources, certainly as we have worked through this over the last number of months, that access to healthcare providers is a challenge for some of the MTFs. And I wonder if you could talk about how you monitor or you balance the access to care for those depending on services. And when you think about additional services that have to be increased, where, in what area is their greatest demand? And how do you track that so you have a sense of where that healthcare dollar is being spent? As you may know, there was a study last year, Shelton study last year, that really looked at some of the contracted services, and they were pretty high, 70% versus the MTF. So can you talk a little bit about that, and how do you do that, and what do you know about that in terms of trying to provide that additional resource?
Well, ma'am, I can tell you within the National Capital Region, we look very closely at where our patients are going to get their care and what we are paying for in the private sector, with the intent of trying to recapture as much of that care as we can. Every time we treat a patient inside of our MTF, there is value in maintaining the skill level of not just the physician or the mid-level provider who's seeing that patient, but the entire care team around that provider. Additionally, if we have the capacity to see the patient, we send them downtown, the taxpayer is really paid twice for that care. And as a taxpayer, I don't like doing that, and I'm sure not many others do. Within the National Capital Region, the needs really revolve around access to services like dermatology, gastroenterology, podiatry, and physical therapy. And I think the rest of the members will say physical therapy has been a challenge for most of us across the military services. And so you look at innovative ways now, how can I bring that care back into the system? And in many cases, what we are doing at Walter Reed and Fort Belvoir is looking at how we can take our providers to where the patient lives and works. And so we have gastroenterology providers living and working at Fort Belvoir and Fort Meade every day. The Air Force has assigned an additional gastroenterology provider to Malcolm Grow, who actually works at Fort Belvoir Community Hospital every day so that we can meet that demand. And we're justifying additional resources in the market, not based on what we're doing at an individual facility, but on what the market needs to be able to take care of the patients that are enrolled to us.
Thank you. And how has that medical dollar been spent then as a result of what you're trying to do? What have you seen that's different?
Well, I think one of the things we've done in the last year in the National Capital Region is we've lowered our per member per month costs significantly, about $90 per patient per month. And that has really been a result of trying to bring that care back in-house and better utilize the capacity that we have. I'm interested to see what happens. We've just hired 11 physical therapists for the entire market, and we are placing those physical therapists at the MTFs where that care is being referred to. So it'll be interesting to see how much care we can recapture and whether or not we can make the care more convenient for the patient. It makes no sense for somebody from Pax River, for example, to drive to Walter Reed for physical therapy 3 times a week if we can provide that service much closer to Pax River.
Great, thank you. Anybody else want to respond?
Congresswoman, I'd like to say too, as Navy medicine and the MHS transitions from healthcare to health, access, service, these are indicators of health, very, very important. So we look at establishing that trust with the patient in a patient-centered medical home model to ensure that it's easy to get access. We monitor every single morning, making sure that our templates are built for open access for our patients. We're providing new and innovative ways for our patients to contact us through Nurse Advice Line, through secure messaging, through our patient smartphone application. We want to make sure that we establish that, because if you need to be seen today, our covenant is that we will see you today, and that's the trust that you build into your patients so they don't seek care in the emergency room. Not that that's not good care, but that's not great primary coordinated care that leads us to health. We also work very closely with our managed care support contractor who manages our network of facilities, and if we see that there's an indication for additional resources to be brought back to the direct care system, we work very closely with them to do so.
Ma'am, I'd like to add as well, yes, we monitor all those things very, very, very closely. We have all kinds of briefings related to that. But I guess the take-home message from my perspective is the metrics don't tell the whole story. If you call today at Madigan, the average time till you're seen for an acute appointment is 0.6 days. Now, the metric that we use for third next available appointment is 1.6 is what that comes out as. But if you call today, most of the time we add you on. We just say, come on in, we'll take care of you. So that's really what I want to get to in terms of access, rather than how many appointments do we have. In terms of the whole dollar figure, we recently went through and kind of reviewed how we do on 37 different kinds of service lines, so gastroenterology, pulmonology, and so forth that we have for the multi-service markets, so 250,000 beneficiaries. For 25 of the 37 service lines, more than 85% of the care we provide inside the direct care system. So yes, ma'am, we look at the value for healthcare dollars. When it makes sense for us to do it inside, we make that business case analysis and we try and provide it internal. If not, if it's more cost effective to do it through a network provider, then we go that way.
Okay, thank you. Time is up.
Ms. Songus?
Thank you, Mr. Chairman, and welcome. As you all are speaking, I'm reminded of, I was a recipient of treatment in a military treatment facility in my early teens, and as was one of my sisters. My father was a career officer in the Air Force, and I've always appreciated the great care we received for not insignificant problems. One was in an MTF here in the United States, another when we were stationed abroad, and in both places we got such great care. So I thank you for that as a family member, and I'm sure, as we certainly hear from our military families, how important that is. I do have a question related to the fact the ever-growing numbers of women that are now currently serving in the active duty. And I'm curious, as this population is increasing, how well able you feel you are able to serve them as they are in this active duty status. And are there shortcomings and ways in which we could be more helpful? And I'll start with you, Colonel Heimel.
Ma'am, I think we've had about a 10-year head start on some of the other federal systems and how we manage women's health. Within Walter Reed, we have a women's health clinic, and there's a range of programs that are available, but we also have the luxury of having an obstetrics and gynecology residency program that allows us to provide a higher level of care for women who are serving, as well as for retirees and the veterans that come to us. I think one of the gaps that we have right now, and it's a matter of developing it, we have just started developing the program about 6 months ago at Walter Reed, is a trauma program for women who are suffering from, and men who are suffering from sexual assault trauma. While trauma is the same from an emotional standpoint, the way we manage that within groups and the therapy we provide really needs a different touch. And so by creating an intensive outpatient program for victims of sexual assault is really, I think, a needed service as we go across MTF to MTF.
Is that a resource issue or an approach issue? How would you define the shortcoming?
Oh, I think it's multivariate. It's an issue of recognizing the need, resourcing it, and then making sure you have the people who have the experience to be able to implement the program.
Thank you. Would others like to respond?
Ma'am, I agree. We've had a little bit more experience with this, and as a former operational medicine consultant to the Surgeon General, I would say we have even a lot of experience going to war with women, which is, I think, given us some perspectives and some understanding what those challenges are. I don't think we have it perfect. I think there are some things we can do, but I think they're more tweaks to the system rather than big gaps that need resources or major renovations of how we approach women's health.
And as women go to war, how would you describe the challenges you have?
So there's a number of things that we look for in terms of hygiene, in terms of privacy, in terms of making sure that we balance security with lighting systems and so forth versus the risk of sexual assault and things like that. There's a number of small factors that come up, but those are ways that, or things that we have to mitigate the risk against rather than create new programs, I think, from my perspective. We have a very active women's health service line that at MedCom that helps us review these things and implement new methodologies. Recently, I would just give you an example for Madigan. An important women's issue is breastfeeding. And we've actually purchased 4 pods for breastfeeding within Madigan because we didn't have locations that we thought were reasonable and accessible for women to breastfeed in. So we purchased them, we set them up, have them advertised and so forth, and we're helping the rest of the installation figure out where to put them, how to utilize them to make them effective for our female soldiers as well as for us, the patients that come there.
And we're glad to see Secretary Carter recognize that it's something that has to be dealt with across the services, not just in the MTF environment, but in general.
Yes, ma'am.
Others like to comment? I have just a little time.
Congresswoman, we're proud at the Naval Hospital Camp Lejeune to have many initiatives. We are been applied for and designated as a 3-star facility by the North Carolina Maternal Center for breastfeeding-friendly institutions. We have started a centering and pregnancy program that I talked about in my opening remarks that according to the Centering for Healthcare Institute, we have the most number of participants in the nation, not just in DOD, with 27 active groups that are going through this group prenatal care program. And I'm blessed in leadership with a partner, my executive officer, who's also a women's health nurse practitioner, make sure that we provide care for all our warfighters and their families.
Thank you. My time's up.
Thank you, Mr. Chairman. Thank you to the panelists for your service today and the sacrifice of your families. On Fort Drum, which is an Army installation that I represent in my district, we have a clinic as opposed to a hospital on post. Guthrie Army Health Clinic and the MedAC that oversees it supports over 14,000 active duty soldiers and 16,000 military family members. Due to this unique relationship, the MedAC at Fort Drum partners with the community to ensure that the highest quality of care is provided to all patients. So I wanted to turn to Colonel Littlefield. What are some of the unique challenges you've faced while partnering with civilian provider networks for services that you are unable to provide? And would you consider a model similar to what you have at Little Rock Air Force Base to be as efficient as other installations that have full hospitals with inpatient care on post?
Thank you, ma'am. I think the opportunity is, or the word is balance, too. It's something when we're looking at access, again, a clinic compared to a bedded facility and what we offer, we're in constant communication with our community partners. Some people don't consider Little Rock as robust, but that's one of the things I found. Their civilian network is quite robust. Now, there are some specialty areas, particularly when you get in the pediatric ranges, some of the mental health services that need to be provided. There are long wait times there. But overall, I've been very pleased with the availability of services. But we partner with them. We do things from holding provider collaborations every year to invite our partners in, meeting with them, developing relationships. We've been able to send some of our providers down to the Arkansas Heart Hospital, seeing open heart procedures and those types of events. So we're always looking for opportunities to partner. And I think with us being the only active duty facility in the state of Arkansas, that is where we're headed, is that we need that partnership for those things that we can't provide. We will capture everything we can, bring it into our facility to keep the skills up of our team members, but we rely on our community partners.
Thank you for that. Does anyone want to comment on that question? Go ahead, Captain Friedman.
Thank you very much, Congresswoman. We're blessed in eastern North Carolina to have a fantastic supportive community in Jacksonville and the surrounding area where they understand the importance of the Marine Corps and Navy team and what it does for the defense of our nation. So our partner facilities in the civilian community have been wonderful for us. We have expanded some enhanced resource sharing agreements with our local hospitals for a dual diagnosis program for dependency and behavioral health. We have our local hospital that provides operating room space for us as we undergo renovation of our operating room spaces. We have a great medical center, Vidant Medical Center, that we've entered into an agreement with to allow our corpsmen, our nurses, and our physicians to be able to go up there and get training that we may not see in our institution. So it's a true community, and I think it's understanding the mission, and I think no one does it better than Jacksonville, North Carolina.
Thank you very much. Any other comments?
Ma'am, I would just offer that I think it depends. Balance is a way to put it, but what we'd like to do, and I think we do a pretty good job of it, is finding the talents and the capabilities in the civilian community, and if it makes good business sense to capitalize on them, then let's do that. If it doesn't, then let's do it inside the facility with taxpayer dollars. So if the capability is there and it's a high quality capability, then by all means we ought to do that.
No, ma'am, I agree with the other panel members have said. I think you have to look at, first, is there a compelling readiness reason why I would want to offer that service, inpatient care, complex surgeries, intensive care, for example, the things that Guthrie gets from the civilian community in my MTF at a particular location. And healthcare is still a very local phenomena, so every base has a different community and different assets in that community to support them. And so if that case is there, we build it there. If that case isn't there, then where can we get that in the civilian community, and how can we build the partnership to make sure that works smoothly?
I appreciate those comments, and we've had success stories in the broader Fort Drum community, partnering, for example, with River Hospital with a very high-quality PTSD program. That's an example of identifying a need and working with the experts and the practitioners who are within the community. So thank you for your testimony today, and thank you for the thoughtful answers.
Thank you, Mr. Chairman, and I want to thank each of you for your testimony and your answers to our questions. And Colonel Heimel, I would just like to thank you especially for your service because I'm most familiar with it when you were the commander at William Beaumont Army Medical Center. And during that time when you were both commander and I was the representative for the area, I probably had 40 public town hall meetings, where everyone was invited, no holds barred, any issue or topic, and you were there at every single one of them, whether Army medicine or veteran care was the subject or not. And I think that sent a very powerful message to the community about your interest and involvement in the community at large, especially veterans care as connected to active duty military care. And then to that point, you did a tremendous job working with our local VA, which is physically conjoined with William Beaumont, while overseeing a $1 billion construction project for the new William Beaumont. So I can't thank you enough for what you've done for our community, for the veterans there, for the active duty military and their families. You mentioned in your testimony the need to ensure that there's a continuum of care for active duty service members into the transition to civilian life when they are veterans. And anecdotally, in El Paso, I will often encounter veterans who served at Fort Bliss, which is served by William Beaumont, who said that for their mental health care needs while they were active duty, they were met almost without fail, without complaint, if their prescription for their PTSD required seeing a therapist once a week, they were seen once a week. And by contrast, in the civilian world treated by the VA, maybe they get in to see a therapist, maybe they don't get to see anyone at all. And we were later able to confirm that through a survey that found that 1/3 of veterans in El Paso could not receive mental health care despite trying. So how do we fix this? If we're able to recruit and retain or make use of mental health care providers who are in active service and do so effectively, how do we ensure that there is consistency and continuity in that care once that service member becomes a veteran at a time when we have officially 22 veterans a day taking their own lives? And I know for a fact that that level of suicide is connected to care that is delayed or denied at the VA. How do we fix this? What have you learned at Walter Reed, at William Beaumont, in collaboration with the VA that would allow us to begin to be more effective in combating this?
Sir, first I want to thank you for your support and your district staff. The partnership we had there, I think, made my 33 months there incredibly successful and really helped me navigate a number of problems that could have derailed a lot of what we were trying to do. And that was the partnership that we had, I think, that really made that a success. Your question is very, very well put. Particularly in the area of behavioral health. There are a number of areas where we have the ability, I think, to help the VA with access to care, and we certainly try to do that at Walter Reed every day. But in El Paso, one of the areas I struggled to be able to support the VA was in primary care services and behavioral health, and I think that's true at a number of our facilities, and certainly true at Walter Reed, though we do have a little more flexibility with the inpatient capabilities that we have. There's a national shortage of behavioral health providers. It's not unique to the military, unique to the VA. I believe nationally we're not filling all the residency seats for psychiatry across the country. We're looking for innovative ways to grow psychology programs, internship programs, et cetera. And so we've got to do something to address the supply at the national level. We're all competing for the same providers, and often what happens is we wind up into a bidding war with the VA or with our civilian counterparts over how we retain providers. And our experience in El Paso, it was very common to have someone work for us for 2 years and then slide over the VA for a couple of years and then come back to us 3 years later. And we've got to do something to increase the pool so that we can meet the demands of our patients.
And it sounds like there's going to be another round, so I'll ask this again, and we'll include the other colonels in the response. But I think my point is that you are somehow able to figure that out. And very often I heard the reverse of the scenario you described, where it is DOD that it's hiring away from the VA, and the VA felt like it couldn't compete on salary or price or benefits or retention bonuses or whatever is provided. So I understand there's a scarcity, but some are able to receive care amidst that scarcity while others do not. And I would just think that if we're treating the same person for the same condition and we're able to do so successfully on this half of the divide, there's got to be some way, perhaps even using the same providers, to continue that care once they are on the other side of the divide. Sure. So I'm out of time, but I'd like to come back to this if there's another round. Thank you.
Thank you, Mr. Chairman. You each are overseeing facilities within a branch within one of the branches of our Defense Department. And I'm interested in whether that matters, that you stay within that particular branch, or whether all healthcare facilities within the MHS could be managed together, which has been recommended. And I'd like to know, beyond parochial concerns, I'd like to know why you think one or the other is more effective for our primary objectives. And we'll start with you.
Yes, sir. Thank you. I think at the end of the day, I think my panel members would agree, we're pretty much blind to who we're providing care to as far as our sister services. We treat, Marines, Navy, Army, all across, even in our facility. And so I think that's the bottom line, is the provision of care and excellent care and how we do it. So
What about on the other end? Does the oversight within a particular branch matter?
Ultimately, I don't think so. I think providing the care, maintaining the readiness for our members, maintaining the readiness for our team members themselves, the medics that need to go out and be ready, and maintaining the care for our family members, dependents, and retirees is the factor that we're looking into. So,
Okay, thank you.
Congressman, thank you for that question. In Navy medicine, as we move forward with readiness, jointness, and value, there's many initiatives that are taking place where we're doing best practices and sharing of resources. We've started in Naval Hospital Camp Lejeune and Eastern Carolina Healthcare Consortium, where we brought together the leaders from Womack Army Medical Center, Seymour Johnson Air Force Base, their clinic there, as well as the VA, to see what we can do to better coordinate care and share resources. However, there are some service-specific things, and the important part of that readiness mission can't be overstated. We are embedded, and the Navy-Marine Corps relationship is so strong. We go to combat together. We have to understand each other's operations and missions, and we have to be trusted partners in leadership. And aboard Marine Corps Base Camp Lejeune, we were very fortunate to have incredibly strong leadership, but bring us in on a lot of decision-making that occurs right there on that Marine Corps base, brings that Navy hospital, make sure that our training is together, our providers work together, they go to war together, they come back together, and there are a lot of specific service-related times where Navy medicine is called for the Navy Marine Corps team.
So that service alignment matters, what I hear you saying.
It does, sir.
Sir, I think I'm in a unique position. I'm in a multi-service market that has Army, Navy, and Air Force in it. So Joint Base Lewis-McChord, McChord is from McChord Airfield, so there's a 62nd Air Wing there, kind of an important unit in the Pacific Northwest, as well as Naval Hospital Bremerton and Naval Hospital Oak Harbor. So I'm the tertiary referral hospital for the two Navy facilities, and actually provide facility space and oversight in IT and logistics and so forth to the Air Force facility that actually is part of a wing of a clinic that we have up on McChord Field on that side of the base. So I would answer it this way. The clinical care doesn't matter. So when you look down from us, it doesn't matter. It's doctors and nurses and so forth applying their skills. That's consistent across all of us. We have the same measures for quality and safety and so forth. Where it gets a little bit unique is in when we talk to line commanders about, what does readiness mean and how do we get there, and the nuances of the mission. And that becomes important, that we speak that language, and there is some service identification with that. The bigger challenge really, I think, for all of us is that we need consistency from us up for policy, funding, all the rest of the things, that if they change a lot, that becomes a problem. And there are some very unique things about each of our services in that, how we receive that kind of guidance and information. So I think from here, it gets a lot more complicated. But for where we are down, it's pretty straightforward. It's clinical care, and we can do that regardless.
Just so we have time for the...
Sir, my situation's a little bit more complicated than Colonel Place's in that we are a joint facility. And I do not have any of the traditional command authorities over the Army, Navy, or Air Force personnel that work at Walter Reed on a daily basis. And one of the things that I have learned is as you get more senior and your organizations get larger, you rarely have all the authorities that you want to do your job effectively. And the premium is built on relationship building and consensus building to accomplish the mission. And that is really what we have done, I think, exceptionally well within Walter Reed and the National Capital Region Medical Directorate, given the fact that as a Defense Health Agency subordinate, we don't have those traditional authorities that my counterpart at the table do have.
Your dilemma sounds a lot like Congress. I yield back.
Mr. Chairman, thank you, and thank you to our panelists. Recently, there was a study that shocked me and probably many of my colleagues that the child abuse among members of our military is much higher than the national average. We're going to be having a hearing on that, I believe, but I'm curious what is being done within the various services in terms of providing specifically mental health services in child abuse cases.
So, ma'am, one of the things that we're looking at JBLM is that very fact. We actually have a higher than expected rate of domestic violence in our units. So General Lanza has charged several of us to figure out what to do about it.
I'm talking about child abuse.
Yes, ma'am. I'm talking about domestic abuse of all sorts,
Okay.
both spouse as well as child. And with that, we use our family advocacy program principally in order to identify families and get them into care. We also have a child and family behavioral health system that we use. We have resources specifically identified to assist with that particular problem, along with all the other behavioral issues that we have for young children.
Anything else?
Congresswoman, aboard Marine Corps Base Camp Lejeune, we're a partner with Marine Corps Community Services that, in addition with our Navy medicine assets, provides training and resources so we can get to the prevention of this problem. We have embedded MCCS family life counselors that enter our clinics as well to make sure there's seamless handoffs for cases that are too significant or clinically important for the Marine Corps Community Services to handle. So there's a seamless transfer there. So there's training opportunities and I would say embedded partnership with our other services.
I guess what I'm asking is, to me, this is a crisis. It appears that if it's 7 times higher, I forget what the figure was, but I think it was something like 7 times higher than the national average, we've got a problem, and what we have in place isn't enough. So I guess my question is more about, are we redoubling our efforts? Are we doing anything differently than we have been doing?
Ma'am, I think we are always looking for opportunities to change how we're doing and deliver the care that's required to intervene in these cases better than we have in the past. And the parallels within our child and adolescent psychiatry community, as well as the adult behavioral health community for the offenders, is how do you develop programs that meet the needs of the victim, change the behaviors of the offenders, and get at the root causes of what's leading to the abuse. Some of it requires criminal prosecutions, and those are run through our service level detachments. Again, these commanders have the authority to prosecute that within their own ranks. We run ours through Army, Navy, and Air Force at Walter Reed. But my biggest concern in my current role is how do I get the emotional and clinical support to the victims, to the support system around the victims, and if the behavior from the offender is related to something like a combat experience or other traumatic experiences, how do we get help to the offender as well?
The issue of chronic traumatic encephalopathy is real. I've been doing some work with Dr. Amalu, who is the coroner who really exposed the issue and the impact that it's having on football players. He's also now looked at the brains of veterans and has developed a technology of being able to do MRIs and do the screening on living persons. And it would appear that within the military we have a serious issue relative to CTE. And I'm wondering to what extent we have done anything to start to screen those who are serving, who suffered subconcussive or concussions, and what steps we're taking to try and address that. I'm running out of time, so maybe if you can't answer it in 21 seconds, you can do so.
Congresswoman, our
Fred.
Intrepid Spirit Concussion Recovery Center has partnered with Team TBI and the University of Pittsburgh to share resources, to share data, to share best practices. So I think this initiative may open up some doors to be able to help our warfighters and then address this problem.
All right, I'd like to talk to you further about it at some point. Thank you.
Okay, we'll begin a second round of questions. Understanding the importance of trying to recapture beneficiary care into the MTFs from a maintenance of readiness perspective for the healthcare provider, so they have that broad array of diverse cases. One of the things that we're wrestling with is how do you incent the beneficiaries to come back into the MTFs? In other hearings that we've had with beneficiary stakeholder groups, one of the concerns that was expressed is that, you know, a beneficiary doesn't like necessarily having a military medical provider, because when that person PCSs or they get deployed, they're starting over with another, you know, military healthcare provider. The other issue that was raised was the inability to get a timely appointment in an MTF. So how would each of you address those two issues? What do you think it would take to incent beneficiaries to come back? How do you address the issues with the relatively transient nature of military health care providers and the capability within the MTF to actually expand access to if we get more beneficiaries to come back in? And I'm going to start with Colonel Littlefield, since we always go this way and you tend to get left out.
Thank you, sir. I appreciate it. Again, I've mentioned the word balance before, but it being a clinic, it is something that we always have to be looking at. We work closely with my staff, my chief of the medical staff in particular, to look at our patient balance. How many retirees, what is the acuity and the complexity of care that we can provide for the provider mix that I have in-house too. I think some of it is communication. That was one of the priorities we mentioned. But talking to the community partners, we go out to the Chamber of Commerce meetings, we go out in the community, those provider collaborations, and talking to the members that are out there and letting them know the services that we have and can provide to allow them to come back in if that's allowed. So we maximize everything we can. We fill up our appointments, but we also focus on the access to care and keep that as a priority to make sure we can get them in. It's not good to advertise services and then not be able to get them to that.
Chairman, I think that this is where the MHS and Navy Medicine is particularly well suited to take care of this issue. The nature of our demographics, our beneficiaries, they're transient as well as they change duty sections or duty stations multiple times in a career. We're blessed to have a system of care that may be unlike anything else in civilian medicine. Our medical record systems talk to each other, so even if they go to one service to another or one institution to another, there is some continuity in that. Patients want to come back to us because we are set up not to produce health care, but produce health. We're looking at things differently. Our remuneration system is different so that we're perfectly focused and aligned right now to be able to look at outcomes. Patient-centered care is getting them to partner in their own health care. And then with generational challenges or generational differences, looking at how access to care is different. What does that mean to some of the millennials? We're using our smartphone technology. We're using virtual messaging. We have appointments that are booked on our provider schedule that are just talking to talking to patients virtually. Evidence-based research has shown that these cohorts of patients that are connected with their doctors do better in many of our health metrics. Our quality is great, and no one is going to care more than our providers.
Sir, I agree with the idea of what is access. I think we have to broaden our horizons a little bit and recognize that different people want different things, and all gets lumped into this concept of access. Right? Some of them want secure messaging. Some of them want to have a nurse advice line. They don't want to come in at all. Others really want to have that face-to-face doctor-patient touch that to happen for them. But I think the biggest thing is that our veterans, our retirees, and our soldiers and their families, quite frankly, want to be part of us. We're the same. You know, we're brothers and sisters in arms. They're our families too. So what I'm trying to do, and I think is most important for us to do, is to celebrate that. To change the culture from, you know, it being difficult to get in to say more that we want them here and we embrace each other. You know, we have the opportunity, I tell my staff this all the time, we have the opportunity to have the best job in the world because we get to take care of America's sons and daughters every day. And we get to work with people like us who really care about them because most of them have some sort of affiliation with the military in some way, shape, or form. Many of them could probably make more money going to a different civilian job rather than staying with us. So I'm really trying to change the culture to say, you know what, this is a special place where we do special things for special people that makes a difference to our country. And once we start having those conversations, my experience has been the retirees say, you know what, I'll do it. I want to come be part of that. And our staff actually celebrates when they do and say, you know, Sergeant Major Retired Jones, we are glad you're back with us today. We are happy to provide you care. I think when we do that, that a lot of those other issues will really go away. I was in with the other representative, Heck, this morning. He told me for us, essentially our complaints about lack of access have declined precipitously recently. I hope that's related to some of that culture that we're working on that really changes the dynamic, I think, of those interactions.
Thank you, Mr. Chairman. You know, I think you just sort of, brought together, I think, Colonel Place, I mean, you know, what's the problem we're trying to solve here? We know that the affiliation is critical, and combined with culture and tradition and a whole host of other things. And at the same time, we have a lot of stakeholders out there who do think that there's some changes that should really be made. You've attacked a number of those, I think, over the last few years, and we've certainly seen changes as many of our men and women have returned home. We're not in the same up tempo that we were, but if you could change something, if you really felt that there's something there that does need to change, not because people are critical or because you think you just have to do it because somebody's asking for it, but is there something that really is important? Because in many ways, I think we come back to arguing the status quo a little bit, even though that status quo is changing somewhat. It's being defined differently, but is that important? I mean, do you think there are some things that absolutely should change?
So, ma'am, let me start this way. I have a fair amount of operational background. I was at Combat Support Hospital in Afghanistan. I was division surgeon in the 101st at the start of the war in Afghanistan. So I've seen what happens. I am enormously proud of my colleagues up here and all that we represent to achieve that 92% survivability rate. When I was in Afghanistan, 98% of the people that came to us alive left us alive. Mm-hmm. Okay, enormously proud of that. Unprecedented in the history of war. So I would just urge caution before we begin thoughts of changing that system. I think it works pretty well. Can it get better? Absolutely, ma'am. I believe that we do need to have more trauma, more diversity, complexity, acuity in our system. It's very hard to have complex surgical cases when you have young, healthy people. So we need to figure out ways to make that happen. But in terms of dramatic changes, no, ma'am. I don't think that at this point that I'm convinced that that kind of thing is necessary. Do we have to have better access? Absolutely. We have 2 community-based medical homes to try and get to where our patients are. We're trying to expand physical therapy at those locations to make it more convenient. We have school-based medical homes, or school-based health clinics, rather, that we're putting in the middle schools and high schools to actually have the kids get care there so they don't have to come out of school. So I think those are all, innovations that are going to help us in this process. Mm-hmm. I think we can do those without wholesale change of the system.
Mm-hmm. Anybody else want to comment on that? And just to follow up really quickly, whether or not we have some more organized ways of helping, for lack of a better term, moonlighting for our men and women to have more formalized connections within communities. There are plenty of communities that do that, but it's more on the initiative of the the individual. Is
Ma'am,
that
do you want me
correct?
to answer that, or?
Well, let me just make sure if you wanted to.
Ma'am, I think, from a moonlighting standpoint, that's really great for the physician that goes out and is able to practice their trauma skills in a level 1 trauma center on a weekend or when they're taking leave. But it doesn't exercise the team that takes care of that patient when the surgeon finishes in the operating room. The operating room nurses, the ICU nurses, the respiratory therapy techs, the folks that manage the blood bank and have to get blood into the operating room during that case don't get to practice their skills. I think a better model is bring as much of that trauma into the doors of our major facilities as possible and co-locate our deployable platforms, the combat support hospitals, forward surgical teams, the Navy FRSSs, at those locations where they can practice those skills every day. But we've got to be careful in how we do this, and I think it gets to Chairman Heck's question as well. When we make that commitment to a community, whether it is to take our surgical teams and embed them in a civilian hospital, or to promise to provide level 2, level 1 trauma care inside our facilities, the next time the kinetic activity in the battlefield picks up, are we going to be able to sustain that commitment to the community and to those retirees, family members that we have brought back into our system? And we have to be very, very careful that we do not overpromise, because the first time we sever that relationship, we lose the trust of those beneficiaries as well as that community.
All right, thank you. My time is up, so maybe we'll get back later.
Actually, I want to give you a little more time to unpack that, because I think that's an interesting idea, and I agree with you. But there's a sort of unspoken side to what you just said about beefing up these facilities, these major care facilities, and getting all of these disciplines there, recapturing care. And the other side is the many, many other facilities in the MHS that are not of that size. And so what do you think has to happen to those? Do they have enough critical mass, in your view, to provide value, or is there a different model that should be used in those non-concentrated areas?
Sir, I think we're already doing that. I know the Army has gone through this recently at looking at a number of their smaller facilities. The MHS modernization report, which I don't think any of us have seen, is still working through staffing in the department and is coming to you for review shortly. I think it really becomes location dependent. Colonel Place and I both served at Fort Campbell, Kentucky. I think we would have the opportunity and the density to be able to do that at a place like Fort Campbell. I think Lejeune is probably a similar size, and so I'll allow Rick to tell you whether or not he could do that in his facility. But I think there's a density and a size, and we've got to be able to look at that from a first, is it sustaining the readiness capability that we need at that location and with those deployable forces, and then does it make good business sense for us to be able to provide that there?
While you're talking, I want to follow up on my prior question from the last round. And I heard different perspectives from all four of you on how important it is for individual facilities to be within a specific branch of the Defense Department. You suggested that it's difficult because if you're in one branch or not, you're in a place where you have to do a lot of collaborating with others, and you have to focus heavily on the softer side of management, the relationship building, the managing up and down and sideways to get things done that you may lack specific authority to get done. What qualities, what management qualities would we need in commanders of facilities that were not, if they were moved, and I'm not implying we will, but if they were moved to a combined medical command as opposed to being aligned within each service, what qualities would you need in commanders that have to navigate that world?
Sir, I think you need the same skill set. The premium placed on my soft skills, my negotiating skills, consensus skills, that I have to use every day at Walter Reed are really not much different at all than what I had to do at William Beaumont or that I had to do at a much smaller MTF at Fort Riley, Kansas as the commander. I think when you reach the colonel level command and really some of the lieutenant colonel commands, you have got to have those soft skills to be able to get done what you need to get done.
Okay. Switching to recapturing patients, particularly at some of the facilities where there's enough critical mass to do it. Are there any specific, and I'll look to others of you now, are there specific incentives that we could offer that might encourage people to access the MTF instead of private sector care?
Congressman, I think we're doing a lot of those right now, and it may even be on the softer side of incentivizing, is with patient-centered medical home and putting the patient in the center of the care and really partnering with them. And as my colleagues were talking about, having them being part of our mission, we have really brought people back to our institutions, probably each one of us, in unprecedented numbers. We've had a 30% increase in enrollment in Lejeune. We've doubled the size of our retiree beneficiaries, which has helped with acuity in our cases. So I think really partnering with them and really discussing the benefits of not a fee-based system and not doing healthcare, not just leaving with a prescription. There's often questions about why don't we have a big billboard that says 4-minute wait in the ER? Now, that's because our ER physicians are phenomenal and our ED is great, but that's not patient-centered.
Could I ask you to follow up and show the statistics that you're alluding to, and then some of the things you've done that you believe have caused that recapture? Because that's at the heart of one of the things we're looking at.
We'd be happy to share that, Congressman.
Thank you.
Thank you. I wanted to start this second round by just thanking Colonel Place for your description of what you do, why you do it, and who you do it for. When you finished, I wanted to work for you. And I feel like we should approach recruitment for these hard-to-recruit specialties, DoD, VA, with that spirit of service and this really unique, extraordinary opportunity you have to do something, you know, profoundly important for people who are doing really important things for this country. And so, anyhow, I thought that was great. I wanted to continue with the question I asked and would allow anyone who would like to answer it to do so. If a service member prior to separation is seeing a therapist every 2 weeks for his or her PTSD, is it possible to continue that regimen once they separate? Is that already happening, perhaps? If not, could it? And then the second scenario is a veteran who is diagnosed with PTSD after their service and is having a hard time gaining an appointment at the VA or a community provider. What's the opportunity to be seen at an Army medical or a military treatment facility? And so I'll begin with Colonel Heimel, since you were starting to answer that, and then anyone else.
Sir, I was going to say, you know, I'm very proud of what we were able to do for our active duty service members at Fort Bliss from a behavioral health perspective, and we had some phenomenal success. We fell well short in what we were able to do for our family members and for our retirees, and we had to lean very heavily on the civilian community to be able to do that. And so what you saw from the active duty side was not what we were able to provide for everyone else. I think we'd like to get to a system where we could have that continuity. I think the challenge becomes, does the veteran stay in the community where they were receiving care when they were on active duty? Increasingly in your district, that's happening, but a lot of districts, there's an out-migration as well, and so sustaining that continuity becomes a problem. Certainly, if we had sufficient capacity at Walter Reed for active duty family members, retirees, and veterans, we would be reaching out to the VISN 5 facilities and making sure that we were using that capability well.
Absolutely. Sir, you're welcome to join anytime. We'll send you an application, and we'll this is a real problem for mental health in particular. I mean, I've talked to our public health department in Pierce County, and one of the concerns that they have is that they have one of the lowest per capita behavioral health, psychiatrists, psychologists, inpatient beds, and so forth. They're trying to fix that, and it's the same time that I'm opening a residential treatment facility for substance abuse within Madigan. So we are literally trying to get the same people to come to work. And so I'm a little concerned, I've expressed that concern that we're in this competition
How
together.
about that specific scenario of a service member being treated, they separate, they're still in the community? Could they go back and see the very same psychologist that they saw at your military treatment facility?
So I can't answer you right here, sir. I would check with our managed care folks, and then probably I think the way that I have to approach that is see whether or not we could do secretarial designee for them in order to get them in for a short period of time until whatever the crisis was.
So in other words, it's not a standard operating procedure.
No,
It
sir,
would
it
be
would
an
all be
exception to do
exception
that.
of policy
Yeah.
for all of those.
And I guess my thought is if, just using the El Paso anecdote again, if the service members with whom I've spoken about this say, while I was at Fort Bliss, I got excellent behavioral health care. If I was supposed to see someone every 2 weeks, I saw them every 2 weeks. When I transitioned to the VA, I did not. If you're able to serve, 100% of the need in the active military and some percentage far short of that in the VA, could you stretch your capacity a little bit to ensure that people are receiving their treatment? Or am I hearing you all say that you are at capacity, you cannot spare additional hours?
Congressman, I think that we talked about relationships, and certainly I'm proud of the relationships that we've established with the VA in our local area. We're partnered with the VA Medical Center in Fayetteville and the VA Center in Wilmington. We've actually embedded a community-based outpatient clinic in one of our branch health clinics aboard Marine Corps Base Camp Lejeune, and started a pilot project where we take at our Wounded Warrior Battalion, where we have our most vulnerable Marines who are transitioning out of the service, and doing a warm handoff right to our branch health clinic to see a VA team, so we don't lose them in the system. They can have some continuity, and I think that that's going to pay great dividends in the future.
Thank you. Out of time, I'll yield back to the chair.
Well, with the panel's indulgence, we'll do something that we haven't done before, at least in my tenure as chair, and that's move to a third round of questions. Colonel Hamel, I'm really intrigued about the command structure at Wally World right now. So you have a director with no command authority, as I understand it, over the personnel within the facility. So who actually does exert command authority over those individuals, and how is that a benefit or a hindrance to the overall operation of the facility?
Sir, I think first of all that it's important to understand and to put it in Army terms, the director exercises mission control for the healthcare delivery mission at Walter Reed Bethesda. We have a very large Army detachment and a very large Navy detachment. The Special Court-Martial Convening Authority that I would have normally had as a Army commander at Colonel Place resides with a Army troop commander who sits on Bethesda. I see him several times a day normally, and we talk closely, particularly on senior NCO and officer issues. And General Becker, the Military District of Washington commander, holds the General Court-Martial Convening Authority. Same thing for the Navy, though now with Rear Admiral Lane as the director, Navy Bureau of Medicine and Surgery has delegated UCMJ authority for the Navy detachment at Walter Reed and Fort Belvoir to Admiral Lane, and so he is able to exercise that for the Navy detachment. Our Air Force, small Air Force detachment, the authorities are over at Malcolm Grow. That really is no different than what my experience was as an Army MTF commander, where I had a medical chain that really had no General Court-Martial Convening authority over my soldiers at Fort Bliss that went through the Fort Bliss commander. And so you're constantly building a relationship with your senior commander on your installation and with your higher headquarters to coordinate, is every privileging action on a physician an officer misconduct issue? It's not. And so it doesn't need to be in the UCMJ chain. And how do you build that understanding? It's through building the relationship with your senior commander and with your medical chain of command.
Okay, thanks. That's very helpful. One of the other issues that we've discussed, again, the whole purpose behind this is and these series of hearings is in preparation for the MHS study and what does MHS look like in the future. And that's why we thought it was critically important to talk to MTF commanders that are really the foundation upon which MHS is built. If you can, just talk a little bit about your staffing models and how you figure out how many bodies you need in your facility in uniform of given specialties. I would imagine it's based on your go-to-war mission and what you're going to need to send forward should the balloon go up. And how do you balance that with then meeting the needs of beneficiaries, when you look at a specific model of having so many in-uniform providers, and your feelings on the substitutions of, an OBGYN can be 0.5 general surgeon if we move forward, and is that the right way to staff for military contingencies? I'm going to start with Colonel Littlefield, if I could.
Yes, sir. Again, I come back to the word balance. It's something we try to look at for the Air Force when we palm out or look ahead, years ahead. We try to determine what that's going to be and have that ability to provide the care to our members. But it does start with what our wartime mission is. At the end of the day, there's no separation. We're constantly keeping people ready. Doesn't matter if it's wartime or not. But if our people are deploying, we have to have those people ready to go at a moment's notice and still take care of the people back home as well. So I would just say project it out as much as we can, discussions with our headquarters, and talking through the benefits that we need to provide our community.
So would you say that, you have a certain number of uniformed healthcare providers based on your wartime mission, and then do you beef that up based on what your beneficiary population is, or do you just look to then get in civilian providers to take care of the Delta? Captain Friedman?
Mr. Chairman, much like Colonel Littlefield, our O plans determine a bit of our manning there with the combatant commanders feeding that information, and it's put through what we call MedMaker, which is Medical Manpower All Corps Requirements Estimator. And in that, we build a seashore rotation base, a platform for our servicemen and women to rotate overseas, those forward contingencies. And then we have the beneficiary mission and the training mission all built into that too. To get to your question on can we flex to meet the needs in the local community, absolutely. We've got a great mix of active duty, as we talked about from that estimate, but also GS and contract staff members all playing an integral role. We've got our GS as our continuity to make sure that when we PCS and transition, there's someone to provide that continuity of leadership and training for the staff. The contract force can be brought in easily to meet mission requirements from our commanders on the base or from working with our managed care support contractor in trying to recapture care. So we've got that base from the O plans, and then we've got some flexibility on the ground as a commander.
Either the other Army colonel, anything different from either of you in that regard?
It's remarkably similar. Once we get through total Army analysis based on the COCOM requirements, we go through a human capital distribution program that then allocates out the uniform members, and then after that we preferentially go to GS, and then when need to, based on time, how long you need to have it, how quickly, and so forth. So we do the analysis based on that to follow it up.
Sir, I think the challenge we have at Walter Reed, as I've learned over the last 5 months, is we're dealing with 3 different staffing models. And we somehow, everybody thinks theirs is perfect. I think there's some really great things about each of the services' staffing validation models. The challenge is, and DHA has been very, very supportive in helping us work through this, is how do we find the right one to support what we are doing and demonstrate to the services that their military staff assigned to us are really getting the competencies and skill sustainment that they need when they go back out to a smaller service platform or when they deploy with their service.
Right. Thank you. Ms. Davis?
Thank you, Mr. Chairman. And perhaps I'll give Captain Friedman and Colonel Littlefield, if you have something you would like to add to the discussion of what should change, what would you like to see?
Thank you, Ranking Member Davis. When you had asked that question, I'd hoped to get to answer it, because when we talk about change, I'm truly excited to be living that change right now as we look at changing from providing health care to health and bringing patients involved in making decisions. When we're looking at outcomes, we're not looking at productivity models, but really getting our populations healthier, which in the long run is going to provide a cost benefit, and it's going to be a more able fighting force. It is a truly exciting time in medicine, but particularly in military medicine and the MHS as we lead the charge on some of these initiatives.
Thank you. Colonel.
And ma'am, I would concur. I would say the focus on prevention as opposed to taking care of an after-the-fact injury or medical condition, educating the patients on the importance of that, and not just the active duty members, but the families, the retirees, and just placing the importance on how much more you can save doing that, then the access to care can become an important factor in that as well, too, and you may not have to rush in to get an appointment if you're taking care. So I would just say the education on prevention.
Great, thank you. I appreciate that. And we're seeing a lot of those changes. Just very quickly, one of the concerns that was expressed here at one point was, shouldn't we have fewer OBGYNs and more trauma surgeons? You all mentioned I think most of you mentioned in your remarks that, you know, obviously there's that preponderance of physicians are really helping to deliver babies, which is a good thing. But what do you say to people when they say, shouldn't they be doing that in the community?
I would frame it a little bit differently, ma'am, if I could. I think we have to make sure that we have a broad perspective. You know, we have to respond to all things. So Ebola, a great example. We have professionals whose full-time job is to look at those kinds of tropical and emerging diseases and so forth. We have folks that specialize in disaster management. So there's a lot of other things that, frankly, the nation's going to ask us to do, and we have to be prepared to do that. So I always become concerned when we talk about trauma management, and that's the coin of the realm for what we talk about when, you know, most of the care that gets provided in theater is not. I'm a family physician, so most of what gets done is what I do. And every now and then we go do some trauma too. Being a combat support hospital commander in Helmand Province with our British colleagues at Camp Bastion and so forth, I understand trauma and I understand how important it is to do that well, but there's a lot of other things that we have to be very good at. So I just urge caution if we say that the thing that's important is trauma, because that is going to leave us a shortfall in a lot of other things.
And ma'am, I think that's one of the things that really makes military medicine unique compared to a civilian healthcare system. Increasingly, as Ms. Song has pointed out, larger numbers of women serving in our force. One of the things that we're seeing is an increase in the number of new cancer diagnoses among our forces every year. A portion of those are gynecological cancers. It gives us an opportunity to be able to manage that from a readiness perspective with those providers in our force. As Colonel Place said, he's a family physician. Oftentimes, the first physician that a wounded soldier sees or sailor service member sees on a battlefield is going to be a pediatrician or a family physician or a cardiologist who's in a battalion aid station. We ask those providers to go through advanced trauma life support and tactical combat casualty care, and then we ask them to actually execute that on the battlefield. Our civilian counterparts do not do that with their pediatricians and their cardiologists and their internists.
Right, yeah.
And I'd like to point out is that taking care of families impacts readiness. It's not just a benefit. This truly impacts the readiness of our nation. I bring our commanding generals from Marine Corps Base Camp Lejeune to our centering room for pregnancy so he can see what happens to the family members, because that's truly a concern of his, because he knows that impacts readiness. So I think that that's important. And the other piece that we do incredibly well in military medicine is as providers to give disposition to the line commanders. That doesn't happen in the civilian communities. You can get a diagnosis, but a disposition. Does this Marine or sailor or soldier, airman, do they need to be on light duty? Can they carry a weapon? Can they do their mission? You can't learn that overnight. That has to be brought up in the system. So I think we're very proud of being able to do that.
Thank you. Thank you all. Thank you, Mr. Chairman.
Thanks. All right, I got one last question. Captain Friedman, you talked about some of your innovative access programs, whether it's using a smartphone or your advice line. Is that a best practice through BUMED, or is that something you're just doing at your facility?
Thank you, Chairman. It's actually brought by Navy Medicine to innovate, and that's what's great about our system, through our regional commands to share best practices with each other. So we're not the only MTF to have a smartphone application. We have an incredible number of downloads, over 6,000 right now, and patients are actually using them. So we learn from each other, but it's not, even though we developed it at Camp Lejeune, it's something that we share throughout the services.
So it populates amongst the tri-service community, not just within Navy Medicine.
The innovation, I mean, it's an individual application for our facility, but the concept is something that we share throughout Navy Medicine. And I think it's going to really, I mean, I'm sure, as you're aware, will change the way that we deliver medicine in 5 or 10 years from now.
Yeah. Colonel Place, you got something you want to add there?
Yes, sir. I'd add, I know of at least 2 Army facilities doing the same thing that have created similar apps, and we've talked with, as commanders, we get together and have opportunities to discuss. So, yes, I think we do a pretty good job overall within the services of innovating to try and keep up with what the expectations are from our beneficiaries. And I think that's important that we do that, and they become best practices, and then we disseminate them out. So that whole knowledge management piece is important, I think, within the services, and I think we're doing much better at that.
Great. Well, again, I want to thank all of you, the 4 of you, for taking the time and hanging here in this very hot room for an hour and a half and through 3 rounds of questions. I found the information very insightful and helpful as we try to tackle the MHS reform study when and if we get it, but certainly in looking forward of how we make the military healthcare system meet its vision of having a dual readiness mission of making sure we have ready healthcare professionals to deploy and we keep our force ready to deploy. So again, thank you all very much. Ms. Davis, thanks for staying so long. I know it's been a long one. And we will be adjourned.